it can be scary for early career injectors because of the complex anatomy, the anastomosis to the ophthalmic artery. What are your thoughts on these safe areas in the temple, and what is your approach to the temple with filler?
So I am of the one up, one over injection with the needle on periosteum. I tend to use either a higher G prime hyaluronic acid filler or poly-L-lactic acid. I transfer half of, if I'm using the pre-filled hyaluronic acid high G prime filler, I transfer half of the syringe into another syringe so that there's, a lot of room for withdrawal. And then I go directly on bone. I withdraw, I wait like 6, 7 seconds. I wait kind of a long time, maybe even sometimes 10 seconds. I have gotten a flash at the very end, and in other areas. So I do, in the higher risk areas, I do pull back for a while with a half empty syringe. And then I do small aliquots constantly withdrawing. I think this is a great review of the anatomy. You can't ever get enough anatomy.
Mhm.
And I think, as with all hyaluronic acid fillers, you approach them with caution because the side effects are real, and nobody wants to have a vascular occlusion. And if it hasn't happened, then they're not doing enough filler. So it happens to everyone. And it's important as board certified dermatologists that you're prepared to manage it, to have the appropriate technique, have your method, and then have a safety plan if something were to happen. And there goes a lot into what's the right technique and the wrong technique. I mean, obviously there are incorrect techniques, but there are a lot of correct techniques. And the more someone does the procedure themselves, they kind of get into their technique, and that becomes, as long as it's within what you're supposed to be doing, kind of the best way for you to do it because you have done it so many times because you've developed and harnessed that technique. It is good to try new techniques. I'm cautious with the temple, so I don't know that I'll be trying any new techniques in that area anytime soon. But the experience, the very, very experienced injectors that are more senior that do a lot of temple filler, they're already doing these techniques. So I think it's all various ways to do similar things.
Yeah, I will say I think the interfascial technique that might be a little bit the most of the learning curve. Yeah, I also mainly do the supraperiosteal planes, and then occasionally subdermal with a 22 cannula, but it's very difficult to go subdermal with the 22 cannula, and the interfascial plane is difficult to find. Sometimes I do think you do need an ultrasound machine, or a lot of the plastic surgeons do it because they're familiar, but these are things. And I know there's a lot of members in the ASDS who are willing to mentor and help our membership with these newer techniques as well.
Yeah, I agree. I always say with dermal fillers, it's kind of an illusion of safety. So you always have to be careful, and I think that um, all of our dermatologists would agree. Safety is paramount. Some people are more comfortable with things than others, and that's okay. But yeah, it's all a learning process and trying different ways to provide augmentation.